giving up an hour of your time to have a bit of a conversation about imaging and the imaging pathway and what's happening in terms of imaging right at the moment. I'm joined by my co-leads across the Southeast, so Bikram Ray Chowdhury, as well as Sean Roberts. Sean, I've seen you in there somewhere, also helping us is Joe Gabbins and Rachel Chappell as the network leads. So the session today is going to be different. It's interactive. That could be really good. It could be spectacularly not so good. So there's a risk that things might not work quite the way that we hoped, but we'll have a go. There's an opportunity here to answer some survey questions to try and get an understanding of what's happening across the region. And we felt that it would be really useful for everybody to see what everybody else was thinking across the region and not just have it said to you from a couple of people who, who are on the call. So if you could keep yourself on mute, keep your camera off as much as possible. Mostly ask questions through the chat function and make comments. It's not that we're averse to having people talk, it's just it gets quite difficult to manage. We will record this, and then there's a summary which will be circulated. And hopefully you'll find it interesting, and hopefully it will work. So let's get moving. So the aims of today is to rapidly collate some views and understand the need for imaging and the capacity constraints which probably most of us are experiencing across the region. Have some discussion on the impact of all of this on the dementia diagnostic pathway, and then look at some possible approaches and recommendations. And it's very much the case that we think it's quite powerful if all of the people who are on the call who are actually facing these issues have a view that's actually something that we can take forwards. So hopefully your voice will count in all of this. So there are a couple of questions that we will discuss through this. The first is, do we need to make a scan do we need a scan to make an informed diagnosis of dementia? Do we need to scan everyone? And if you were going to select, who really does need a scan? And then a question that is quite important for not only now, but for the rest of our diagnostic practice is, what do we actually want from a scan report? And are we getting what we want when we request it? So I just wanted to very briefly, before we go to the survey, to just highlight pretty much what we're trying to do here. So, of course, we're all trying to make this diagnosis of dementia, and dementia is both a clinical and a pathological diagnosis. But we start with an at-risk population, and some of those will have subjective memory complaints at some point. But of course, the at-risk population includes a whole lot of people that don't have any symptoms at all yet. It's just that the whole process has started at a much earlier stage in life, and they aren't symptomatic at all. But we start with people who have subjective memory complaints, and we're trying to identify what the risk of them progressing is. But we also have a fair amount of opportunistic screening that occurs when people are in a GP surgery, for example, or in another medical setting, and somebody realizes that the situation isn't quite as it should be, or a carer, family member is concerned. So within that population, we do a series of things to try and work out who we should pay more attention to in terms of possible dementia. So there are various screening tools, there are various questions that we can ask. But we come to a certain point where it's more than subjective symptoms. And of course, subjective symptoms overlap quite a bit with normal experience. So it can be quite difficult to separate these things out. But there's a point at which somebody has objective cognitive decline. And you can measure that through a range of instruments. The more detail and time you put into those instruments, the more likely you are to get something out of them that is useful. But at a certain point, that becomes reasonably definitive. Problem is that this is still only a risk state for progression. And of course, you can end up with mild cognitive impairment, which means that you're not functioning at your optimum level, but you may not necessarily progress, or you may progress. And what we're trying to do again is to stratify out those people that are going to progress, because they're the ones that are going to have more trouble. And they're also the ones that we potentially can help more. Hopefully in the future, there will be more to offer. Right at the moment, of course, our ability to help in terms of therapeutics is minimal, but our ability to help in terms of support is not at all. And if we structure our services right, then we can obviously do that well. And ultimately, then that group drops through to people that actually have dementia. But all the way you're stratifying and reducing the number of people that are involved. So here's one of the problems that that we face, and the issue here is that it's quite difficult at certain points to diagnose dementia. It's very easy if you look at this curve on the right-hand side, the extreme right-hand side, where you have the green section. Those people who have moved through the normal MCI stage and into dementia, it gets easier and easier to tell. You don't need lots of fancy tests when people have got to a certain level of cognitive impairment. But if you want to push that threshold of detection back in time so that you get to an earlier and earlier point, actually, sometimes this gets quite difficult. And we've got a range of tools to help us. We can use imaging, either structural imaging, such as MRI and CT. We can use imaging, functional imaging like SPECT and FGG. But all of these are trying to push that diagnostic point back further towards the earliest time. And we do this because we think that actually if we can diagnose when people are getting symptoms, and we can do it with the minimum amount of fuss, we'll actually give them a better experience. And over time, if we can do this well, then when there are therapies available, we'll be able to implement them at the earliest possible opportunity. But this is our constant tension is that we're trying to push back to earlier thresholds of, or sort of earlier points in time. It means our thresholds of detection become more difficult to broach, and the modalities that we have access to need to become more sophisticated as we do it. And there is a dynamic influence here under COVID in that we don't have access to some of these things. And I guess we have to ask ourselves the question at times is, what are we trying to actually achieve in all of this? So you know the sorts of things that we have, and you know that there are various guidelines on this. Generally, the feeling is that we should offer structural imaging, rules out reversible causes, assist with subtype of diagnosis, unless, of course, the dementia is well established and the subtype is clear. Of course, I think most of us have been faced with a situation where we're having difficulty with more than that because we're not able to actually see some of the people that we normally would be seeing face to face and testing in different ways. These are the sort of some examples quickly of the other types of imaging that we often utilize. So in some areas in this region, we'll use SPECT scanning. In some areas, we'll be using FGG PET. And in some areas, we'll be using DAT scanning, largely to help us with Lewy body dementia. The other two can be the Lewy body disease or Alzheimer's disease. And here's the nice guidance, and it was updated in 2018. And really, the issue was structural imaging to start off with, and then if the diagnosis is uncertain, particularly if you're looking for subtypes, then the other tests may be more useful. Again, and the reason for this discussion today is that life's not quite so straightforward at the moment, and some of this guidance may not be helping us in the current circumstances, but that's for us to discuss. So here largely is the crux of all of it, and after this slide we'll go to the survey and hopefully things will stay on course. So if you take this timeline that basically moves from disease onset through to the end of life, there is a period of symptom onset, which is really quite variable. It happens quite some time after the disease usually has started to occur, and that doesn't matter which dementia you're talking about. There's a diagnostic threshold at a particular point, which varies depending on the modality that you use, whether it's structural imaging or functional imaging. It also depends on whether people have symptoms at a particular point as to whether they even come to your attention. And then there's a point of disease progression where you're largely dealing with symptom management, but in that point of disease progression, you may have an opportunity to check that somebody is actually declining, as in they have got a degenerative disease, as in they have got a dementia. So we've actually got a threshold for diagnosis that occurs along this line of this dotted line, all the way from symptom onset, where we would we often need to use more sophisticated imaging than we currently have available to be certain, but in many cases we don't. through to a point where diagnosis becomes easier with a range of different modalities, depending on which one and which individual, and then a point during disease progression where even if you don't have imaging, you might be able to confirm your diagnosis, because if you wait long enough in these types of conditions, you will always find the answer. It becomes more straightforward. But of course, then people miss an opportunity to have their dementia diagnosed sooner. So what's going to happen now, if this works, is that in the chat, there should be a link that emerges. And what I'd like you to do is to click on that link, and it'll take you to a survey. The survey is just basically trying to understand a bit about your experience of imaging and imaging requesting. Just pay attention to when you're asked about whether it is now, as in the time of COVID, or whether it was before COVID. But if you could start filling out that, that form, what we'll be able to do is to actually see the results, and then we can talk through some of those results once everybody's had a chance to do that. So I'm going to give you five minutes to go through to that survey. I will occasionally direct new people who are arriving to the survey. If you don't finish it, you will get a chance to do it later. You will need to save the survey at the end. There's a save button. There is only one question that is mandatory. The rest are all voluntary. And then I will share the screen so that you can see what everybody else thinks. So hopefully that's clear.
So we've had a couple of people join us since I posted the link in the chat for the survey. So if you've just joined us, everybody has now clicked the link that's in the chat and is taking part in a survey, and then we'll have a look at everybody's responses in about 3 or 4 minutes' time. Couple more people are joining at the moment. You'll hear silence as everybody is concentrating on filling in the short survey. The link to the survey is in the chat box. So if you want to click on the link and then have a quick look through the survey and quickly answer, we've got a couple of minutes left before we go back to the results.
Sorry, Rachel, but I cannot see the link. I don't know if I joined later or it's not in the chat box.
Okay, I can post it again.
I can't find the link either.
So the link is in the meeting chat box.
Yeah, it's not.
Rachel, I think the problem is that you only see the chat after you've joined.
Oh, okay, I will
reposting it as you have done will work.
Okay. So everybody who has now joined should be able to see the link to the survey.
So there's another way to reach the survey on the screen at the moment if you need to. So there's a mention there that if you're not a clinician, yes, Rachel's responded to it.
Okay, I've re-entered the survey again for Simon Hellier, who's just joined the meeting. Simon, we're just all filling in the survey, the link to which is in the chat box. There's a couple of moments left for you to have a quick look at that and complete it if you'd like to take part. And then we're going to have a group discussion around some of the results that everybody's filled in. And that's 5 minutes, Chris, from the first posting of the link, but we might want to give a couple more moments to people that have come in late.
I think so. Good.
Let's quickly say hello and welcome to Rakesh Kiora. Not sure if I pronounced your name right. You'll have joined to what sounds like a very silent meeting. Everybody at the moment is just filling in a short survey, but you might want to wait until the next survey or take part in the survey. I'll post the link in the chat box again for you if you want to take part.
Sorry, I'm
in
late.
a moment, we're going to have a look at everybody's responses. Doesn't matter if people are late, you can still click the survey link and take part. We're still gathering responses.
Okay, I'm just going to give another minute or so to finish off. So can you make sure that you save your results at the bottom, even if you haven't completely finished it? It would be helpful if you just at the end of the next minute or so, just go down and save it so that we've got the results that we can use. Okay, so we've got 32 responses, and it's taking 3 minutes and 14 seconds on average to complete. So could I ask anybody who's not finished yet to save this, and then we'll just run through it and then have a bit more of a conversation about things as we go. So just 34 responses.
We've currently got 55 people on the call, Chris, so a couple of people are clearly just finishing off and reading through.
Okay, well, I think there's enough to work with in terms of a discussion. So we've got what we wanted to just see is what kind of the mix was in terms of people on the call. So we've got here you can see 22 clinicians, there's actually 31 clinicians, but 22 are actively involved in diagnosis of dementia and 9 not actively involved, 3 non-clinicians. There's a fair range of people from across the region, which is helpful, so we should get an idea as to what everybody's thinking. And here's an interesting metric. So is a scan needed to make an informed diagnosis? Well, I think the answer is 50-50, absolutely split. So this is a controversy that sort of comes and goes at different times. But I think there are differences of opinion on this, and I guess it probably comes down to the detail, which is often the case. And what we've got here is how important is it to make a brain scan and making a diagnosis of dementia. So the way to read this is that minus 100 would be not at all important, plus 100 would be extremely important, and in the middle is sitting neither here nor there, essentially. So on balance, exactly the same as the question before. So this question here is going to be more difficult for us to interpret. What proportion of the time would you request a scan when making a diagnosis of dementia? So if we go into that, what we can see is that there's quite a wide range here. So 85, 40, 75, 95, I'm sure we can get an average, but it seems to range anywhere between about 40% and 100%, with the majority of people organising or requesting scans on the majority of occasions, even though everybody's quite clear that you don't need to use a scan absolutely every time when you're doing this. So in terms of what scans do you use? So you should be able to see question 6 here now on the screens. So the way to read this particular slide is at the top is the key. So orange, bright orange, is less than 10% of the time, and blue is greater than 90% of the time. So before COVID, people were most of the time essentially ordering a CT scan, and that would be the scan that you would request sort of over 90% of the time, to a lesser extent in another group. MRI scans would be requested less often. I guess that makes sense. And then PET or SPECT scans ordered far less often, but then that's a secondary diagnostic tool often, and usually done after some structural imaging is done. There's also not universal access to those. So the question here is, how important is having a brain scan and making a diagnosis of dementia now? So I guess what people are telling us at this particular point is that actually the need to have the scan has dropped. There are more people who would say that you don't need to have a scan than before. And here we get the metric as to what's the story with imaging. So right at the moment, interestingly, some people feel that access is better. The majority of people, however, here feel that the access is worse getting brain imaging. So it is more difficult, and I think probably what we've got is a response from people to suggest that it's more difficult, so we're not actually going to use it. We'll use other ways of doing things. So what we wanted to assess from everybody is this: what do people feel is the most useful role of actual scan? So admittedly, there may be more than one answer here. But often think this through, but I think that people are very much favouring the fact that the scan itself is going to be useful for excluding non-dementia causes. So I guess that's an important issue, is that in many ways this is a safety step as much as anything else. And in fact, it's more useful to exclude non-dementia than it is to confirm the dementia diagnosis. And I think most of us would have that experience, is certainly when you're using a structural scan, you'll rule out other problems, but you won't necessarily rule in dementia. And then, in fact, the scan is probably more useful at diagnosing the dementia subtype than confirming dementia diagnosis. Now, the interesting thing is that might not necessarily be what people assume, is that people are assuming that we're using scans to confirm the diagnosis, when actually we're probably doing something else with a structural scan. So I have to think back through this question. Select on your reasons for performing scan best. I'm just going back to, so I can just remind myself exactly what. To rule out dementia, confirm a dementia diagnosis. So there we go. So basically, again, confirming exactly what has been said before, is that on balance, you're much more favouring the scan as ruling out another problem. How confident are you about making a diagnosis of dementia at the moment? I think people, it seems like they have lost some degree of confidence. and all things considered, how would you rate your practice at present? That question was really about risk management versus active dementia confirmation, and what's the balance between telephone and face-to-face assessments in your area. So on the effectively the detractors side, which is the negative side, the balance is absolutely in favour of telephone assessments versus face-to-face. So we've all found the same types of problems, is that we are not seeing people face-to-face, we're seeing them largely on the phone. It is having an effect on risk management versus confirmation. And we are looking at scanning as a management of risk as much as it is a confirmation of dementia. So that would suggest that there is still a fair pressure to do scans despite the circumstances. So I'm going to try now and come back to the presentation. I might have to step through it, and apologies if I do. And we'll just... Yeah, so I'll just step through the presentation to where we were. Okay, so I think here's the question that we need to highlight is what's the purpose of brain imaging in dementia, and has that fundamentally changed? And I think the underlying reasons look like they haven't changed, is that we're trying to rule out things, and we're also trying to actively confirm a diagnosis. But I think the purpose at the moment seems to very much be an issue of ruling out problems and managing risk. What I'd be interested if people could comment on in the chat, and Vikram and any others that want to comment, is that the sense that you get at the moment, is that actually scans are being used to rule out other problems, and actually that's still a necessary and important part of practice? And maybe if people could comment on that in the chat separately.
So thanks, Chris. I was just reflecting on my experience as a GP. So if I was diagnosing dementia, I would probably be doing that in a care home, and I probably would either not refer for a scan or have very little access to a scan. But that's purely advanced dementia. So I suppose in secondary care, if I'm diagnosing more earlier onset then or earlier stage of dementia, then the need of the scan is perhaps more important to rule out other diagnoses. So that made me think of the nuances of where we are. So that's was just a comment that I thought was relevant in this case.
Yeah. So thanks, Vikram. I wonder if any others feel free to come off mute for a moment and comment. So is the general feeling is that at the moment, with this difficulty in actually seeing people face to face, that there's a really important component of management which involves ruling out other things. And one of the advantages, in a sense, of being in a care home is that you've got a protected environment where people are able to be reviewed. So you've got in a way a safety net. But when you are doing this with people at home, it is tricky, and it's tricky to get it right. So I wonder if there are any other comments that could either come through the chat, or could if people would like to comment directly.
Hi, Chris. It's Balaji, one of the old age consultants from Portsmouth. What I find is we obviously are getting referrals with the very early stages of dementia. In olden days, or a few decades ago, we would have called it as only mild cognitive impairment and wouldn't have done anything to improve and increase the confidence in diagnosis. We also tend to use neuroimaging, as medial temporal atrophy is seen as a biomarker for dementia as well, Alzheimer's type of dementia. So it's also for that reason we do neuroimaging.
And do you feel at the moment that imaging is more or less important when you're trying to make diagnoses, particularly when you're not able to see people, or do you think it's just as important as it ever was?
And I would actually hesitate to request imaging without actually seeing and explaining. Very rarely I have done that. I think recently in the last 6 months, I would have done it for about, say, 2 or 3 patients when they would have seen other clinicians such as geriatricians or other, and they ended up in the hospital and they were very prone to delirium and such cases where we are almost clear that they have a very vulnerable brain. They're more likely to develop cognitive impairment with a very slight change in their homeostasis. In such cases, yes, I would, without seeing the patient.
So, thanks. I guess the question I would ask is imaging is limited at the moment. It's difficult. It's one of the facilities that's probably under the most pressure across the region. And that's because the scanners are taking longer between people, and there are a number of other conditions that are claiming priority. So I guess the question that I would ask here, and this is really to just help everybody else on the call who might be struggling with this, is if you simply lost your access to imaging, what would you say the best approach is? How do we best manage that?
Again, I suppose, Chris, as a GP, and I presume for all clinicians, the first thing would be to make sure the patient is safeguarded. So it depends on the needs of the patient. If we are in the very unlucky situation of not having any access to scans whatsoever, then I suppose we would be defined by what's in the patient's best interest. And if actually there was a suggestion, like I think Sean has made a comment about early young onset symptoms, you're probably looking at other disease. In that case, pushing for a scan is probably very important. So it depends on where the patient profile fits, what's the most likely diagnosis is where I would adapt my practice.
Okay. It looks like there is a question, hand up from Lola Martos. Lola.
Thank you. Sorry, I'm one of the old age psychiatrists in Oxford. I think imaging is actually quite important, and I don't see why. I know is the getting a CT head scan may be more difficult now, but for some patients had been life-saving to have and scan and to rule out tumours or other conditions. So I think it is important that we also empower a little bit of what dementia diagnosis is and the access that we have to proper tools. And the more we do it, the better we get at it. So my opinion is that we shouldn't be diminishing the importance of the scans in dementia, and when we have a shortage of them, I think we just have to prioritize them in secondary care for the patients that come earlier on, possibly in the illness. It is quite important. I understand in primary care, when you're in a care home and it's a back door, dementia is a bit of a different situation, but I think we just have to look at the individuals, the profile, and I support what just been said. So
No, that's very helpful. So Richard Brown.
Yeah, I mean, just sort of responding to your question about what you do with no access to scans, and I think it also links with what do we do with no access to patients and doing things over the phone. I think if I had no access to scans, I would, obviously dementia is a clinical diagnosis that doesn't require a scan. It is really about subtyping when we're getting to the scanning stage and perhaps predicting those people who've got MCI and borderline MCI early dementia as to who's going to sort of progress in the next few years, whether they've got biomarkers that would sort of predict that. I think my handicap also is where I can't see people who may have neurological signs that might predict Lewy body disease or something similar, which is the real sort of worry with telephone consultation at the moment. One can screen for symptoms and signs and secondhand information from families and maybe try and find a way of seeing selected people face to face, but that's a real difficulty. And in some ways, people with obvious neurosigns are the ones that are easier to diagnose clinically, where perhaps, oddly enough, a sort of scan might become less important if they're overtly Parkinsonian. But it is hard answering questions about the role in dementia diagnosis, because I guess it's maintaining that distinction between a sort of clinical dementia syndrome and being clear about the underlying cause and the immediate prognosis over the next few years for the underlying cause.
Yes. So I mean, one of the reasons why we wanted to sort of structure the seminar like this was to try and get a range of different opinions. And I guess what we've seen in the last couple of comments and some of the answers to the questions is that subtlety in this. It's not just you should always do a scan or you should never do a scan. It's that you've actually got to think through the context. You've got to think about what you're trying to do. Are you trying to rule something out, or are you trying to make a subtype diagnosis? And I think right at the moment, all of those questions are quite difficult to answer. Because if the access is limited, then you're going to have to make some decisions without the imaging. And if there's a question of priorities, sometimes some of the things that we would normally prioritize, we're going to have to deprioritize. The difficulty I perceive is that over 6 months, I don't think the access to imaging is necessarily going to get any easier. And I think that all of our social distancing requirements, both for assessing people face to face and in terms of requesting imaging, are going to remain. And so we have to find some way around this. So I guess this question has really been to try and prompt some thinking about what is it that we're trying to identify from scans? What is everybody else trying to identify from scans? And how would we make that decision? And hopefully by discussing it a bit, it makes it a bit easier for people to justify what they're doing and feel confident about it. I think from the results of what we've got from the surveys, I think that people are finding it more difficult and are less confident, and that they're focusing on risk management rather than, and you know, it may or may not be to know that. So I guess the question of who really needs a scan, I guess possibly to summarize, comes down to, well, what are you trying to show and how important is it to show it at this particular moment? Okay, so are there any other comments on that? I'm assuming, Richard, you've got your hand up because it was still up, as opposed to you've got another question. Okay.
Hey, sorry.
That's all right. No, that's all right. Just checking. So I might pass on slightly and just clarify where we're going with the next part of this. So the question then here is, you know, do we need a scan? Well, we've answered a fair amount of that in terms of what people think. Do we need to scan everyone, and who really needs a scan? I think we've answered that. But we should hear about what we actually need from scans. And one of the difficulties that I think we send people off for a scan, and what comes back is not necessarily that helpful. So the report is ruling out things. It tells us it's not X and it's not Y. There are often changes on structural scans, particularly CT scans, MRI scans, of course, as well, that are actually present but aren't commented on, and that limits their potential usefulness, because I think sometimes people end up with requests for a second scan or a scan of a different modality to try and alleviate that deficit. And what I was interested in really was to try and understand what it is that people actually would value from scan reports, because again, this is a point of pressure that we can apply. If people are asking for things as a group and it's important, then we might be able to improve the scan reporting. So I think there's often not an issue with, has somebody reported the scan well, in terms of, you know, have they successfully identified any abnormality that risk. I think that often not much communication of what would be supportive of a positive diagnosis of dementia. So what we should have now is another link. This is shorter, so we won't give as much time on that. But there's another link now in the chat, which is just about scan reporting. And again, it would be helpful to know if you're a clinician or not. And even if you're not a clinician, feel free to respond to this. It's for us to have this information, and we'll then separate it out by clinician versus non-clinician later. But it will be interesting to do that comparison, because there are things that people who do this all the time will think, and there will be perceptions we'd like to compare. So link to survey number 2, and we'll give you 4 minutes for that, and then we'll just discuss after that. I can see that 4 of you have finished it already. 5. We're up to 11. Now 20.
Just for the couple of people that have joined the meeting just recently, welcome to the meeting. Currently, everybody on the call is answering the questions in the survey, the link to which is in the chat box. So we're going to call people back into the meeting in a couple of moments, but if you've got a couple of moments and just want to quickly click through the survey and press submit at the end, then your answers will get joined in with the group and we can discuss them afterwards.
Okay, we're up to 37 responses, and I'm just looking at the time, so I'll give another 30 seconds, and then we'll just come back through. Okay, so if you've still got to complete it, feel free to. It'll save the responses, and we'll use that in the final reporting back. So so here we have the first metric. So what we were interested in is what's needed in terms of images and image reporting. So there's a spread of opinion that having access to the brain images directly is somewhat important, not absolutely essential on balance, but overall is there is some importance and people seem to want that. Very important to have a detailed description of the imaging findings in the report. a number of people are quite keen on having the metrics, but again, this is there's a balance here. All of these results are suggesting that these things are important rather than being unimportant. Very much in favour of having specific comments on the findings in relation to a possible dementia diagnosis, and a similar sort of level of enthusiasm for a statement on the level of confidence. I know that's sometimes quite difficult to actually give that. And then recommendations for further testing or repeat imaging. So there are a number of features, and these questions were put there for a particular reason, because we have reason to believe that these are the areas that people are finding difficult. But it would be fair to say that across the region, people are absolutely endorsing that these things should be in imaging reports. They don't have to be long, they just have to include these areas. So in terms of the imaging reports, do people feel that they actually help them make a diagnosis of dementia? So I think, again, there would be a net feeling that, in fact, they probably don't help as much as as people would like them to. That's not to say that it's necessarily easy to change, but there is definitely some enthusiasm for people to improve the reporting. I'm just going to click on the details so that you can see what various colleagues have said about the main reason for why they chose the particular score that they did. So this is actually quite interesting. So it's frustrating when there's a lack of useful information, but actually what's often being used here is a kind of independent corroboration between the clinical findings and the imaging findings. So that actually it's an additional step to just make sure that you haven't missed anything, that you haven't failed to consider things. So, so we've got all of these things in here. Sometimes it's really not terribly helpful. Sometimes it helps just simply corroborate and support the clinical findings, suggesting that there isn't something that's being missed. And then in the fourth response is when it's done very well, and actually there are appropriate metrics and an opinion, then it's very helpful in not only corroborating, but it seems to complement the clinical assessment. So then, of course, from the perspective of general practice, that actually scans are less of an important issue. And then there's a comment on subtyping. So hopefully just seeing what everybody else thinks, and hopefully this mechanism of showing you what everybody else thinks is helpful in considering your responses to imaging. I'm just going to close that. And again, this last little metric here was just to show you that people who were responding were a range, including clinicians who actively diagnose and clinicians who don't. So I'm going to share the screen again at the end, and my apologies that I'll have to step through the presentation again, but then you get to see it lots of times. I'll just be one moment here. Right, let's move that on. Okay, so I guess this is the point we're at, is that how helpful do you find imaging reports for dementia, and what do you need to make them useful? What can be done to improve the usefulness of imaging reports? So you've seen what everybody else has had to say about this, that it varies quite a lot, that there would be specific things that could be included that would make them more helpful. And I was just wondering from anybody's comments, either in the chat or coming off mute to just comment, is there anything that you feel has not been included in there, or any comments you'd like to make on the usefulness, the benefit of imaging reports, and what could be done about it?
Chris, Bikram here. So just a clinical scenario I had about a few years ago was the relatives of the patient who just come into a care home. They were very worried about the diagnosis because their interpretation was it had not been confirmed, and they wondered whether further assessments were necessary. But when I looked back through the notes and saw what had been happened, this was clearly a new patient to our surgery because they'd just come into our local nursing home. The availability of reports and things made the whole thing easier for me to understand and then translate to the relatives, and then give them, I suppose, a sense of closure with the diagnosis. So in that sense, I think having a documented, detailed assessments and reports and sharing that information, I think, is fairly useful, and I would certainly recommend it.
So that's interesting. So if we go back to the point where we were looking at the results, saying what's the sort of the single most important reason for doing a scan, and we had a range of different things, and one of the options included in that was to help patients and carers feel confident about the diagnosis. And I guess one of the things that we may not necessarily always consider, but becomes quite relevant in the discussion that, in the situation that you've literally just described, is that right at the diagnostic time, the clinician might be completely satisfied that they've done everything to rule out or, confirm. But if the individual and their carer isn't convinced, it becomes very difficult. And so one of the things that, I'm always amazed, impressed, puzzled by, I don't know, probably all of those things, is the power of something in black and white for somebody to help accept that this must be so. And I guess that's, a part of the imaging and the imaging reports that doesn't necessarily become immediately apparent at the time of diagnosis, but may well become important for people to accept that on a longer term basis. So that, I think that's a helpful point. Anybody else with comments or anything else to say? And then I can, if not, I can wrap up with the last final points from us. And just give you a moment to. Richard.
I'll just come in briefly. I mean, I wonder how much people's views are influenced by what they're used to dealing with in terms of their local practice and local area. I mean, I wonder if your response would be different if you're habitually used to sort of Queen Square reporting and access to PACS, and having sort of more nuanced conversations, and perhaps how much you'll just get used to taking a very pragmatic approach if you have maybe limited access to CT with very basic reporting, and whether the sort of spread of responses is partly indicative of what people are used to dealing with. I don't know, but it's just a thought.
Yeah, look, I'd be inclined to agree. I think we get used to our practice and we get used to a certain level of certainty about things. And I think if you're quite used to having a scan, it's really quite uncomfortable not to have it. If you're used to making a diagnosis and not needing the scan, then you wouldn't necessarily think twice about it. So I definitely would agree with you that what you're used to makes a big difference and is likely to define what you do. And all of us are in the situation, I think, at the moment where what we were used to is not the same. So this is the opportunity to think through, what times are we going to do something that is different, and are we justified in doing it? So good point. I think I'm going to move us on, unless there's another comment coming through. But the last kind of points just to make is I think I don't claim that we've got any answers to any of this. We weren't necessarily planning to propose a specific way of doing things. What we wanted to do was to just highlight some of the issues that are likely to be facing people and give everybody a chance to think this through for a short period in their afternoon, and hopefully see what everybody else is thinking. And we'd be very interested to know whether that approach is useful. We've been experimenting with this approach and it may not have worked and you may not have felt that it was worth your time, but it would be very helpful to know one way or the other. So before you leave in a moment, it would be great if you could just give us your honest opinion as to whether something like this was a useful session, because we'll use that feedback to then define other things that we offer. And in terms of what we will offer, So the next steps in all of this is that the recording of the session will be available. We've got the responses all through the survey, and we will collate those and circulate them, try and make some interpretation. We may be able to make some suggestions, and I think it is helpful for us to be able to use this information in terms of any of the discussions that we have at an access level or commissioning level. We've got more things coming up. There'll be a session on delirium on the 5th of November. We'll circulate that, and there will be a discussion about dementia and care homes. We haven't confirmed the date yet, but we'll be doing that shortly. So I'm not sure if any of my other colleagues on the call want to have a final comment. But
thank you, Chris. I think this is an innovative format, and I'm intrigued to see what others say about this. But thank you for doing this.
Well, it's been an interesting journey in getting it right. So, okay. Well, look, I think thank you all very much for your time. We're pretty much exactly to time. So thank you for joining us. I hope it was helpful. And as I say, please give us your feedback so that we can utilize that for how we do things the next time. And enjoy the rest of your afternoon.